Thank you, Terry, and good afternoon, good midday to all of you all. We're very excited to have you with us, and NAMI is very excited to host this series. And on behalf of our board and our board president, Shirley Holloway, our NAMI staff, and our NAMI national state organizations and affiliates, we welcome you to this session on today. And we're very excited to have you with us. And to get us started, I'd like to introduce you to our Chief Medical Officer, Dr. Ken Duckworth. Ken?
Good afternoon, everyone, and thank you for joining. As you know, this is part 2 in a 4-part series looking at creative alternatives to help people get help, not handcuffs. Today, we're extremely fortunate to have the leadership of NAMI's policy and advocacy arm at the national office, and also a special guest from CAHOOTS, which has the all-time greatest acronym I've ever seen. Crisis assistant helping out on the streets. What could be a better definition of creative alternatives? Our speakers are Angela Kimball. Andrew is our National Director of Advocacy and Public Policy and is a major force for good in unifying the voice of multiple mental health organizations to get results. Hannah Wesolowski is our Director of Field Advocacy, and Hannah connects to the state and local affiliates to conduct an orchestra of field advocacy. And Ebony Morgan is a registered nurse and the director of the CAHOOTS program at the White Bird Clinic. Ebony is driven by a passion for addressing the effects of socioeconomic inequalities and structural racism on public health and safety. And she's going to be teaching us about what many consider the national model on a creative, mobile approach to people in mental health crisis. So I want to thank you all. I'll turn up again at the end for Q&A. Dr. Brister has told you how to submit questions, and I'll be doing my best to sort them and to get a good conversation going among our experts. Thank you all.
Thank you for your introduction, Ken. I'm Angela, and in the second webinar in our Help Not Handcuffs series, we'll provide an overview of the kind of crisis response system NAMI would like to see across the country and share with you what's happening at the federal and state level to make this happen. I want to begin by sharing some reminders of the trauma and tragedy of inadequate crisis care. People with mental illness end up on our streets, in our jails, and in emergency departments every single day. And between 2015 and 2020, 1 in 4 fatal shootings by police were of people with mental illness. And of those, 1 in 3 were people of color. And over 2 million times every single year, people with serious mental illness are booked into our nation's jails. And finally, the rates that people are dying by suicide or overdose are simply unacceptable. Our people deserve help, not handcuffs. Fortunately, there's a real opportunity to change the paradigm for crisis response, and it starts with 988. So, what is 988? I think our slides are are just fine, so I'm going to stop there and say, so what is 988? 988 is a 3-digit crisis line number for people in a mental health, substance use, or suicidal crisis, and it's going live across the country by July of 2022. And as you'll see from this timeline, 988 was recommended a couple of years ago and formally established last year by the Federal Communications Commission, or FCC. Then 988 was ingrained in law through the National Suicide Hotline Designation Act that was signed into law last October. Now, while 988 is a number for our crisis line network, it forms the foundation for reimagined crisis systems that can provide a mental health response to mental health crises. Before we talk about the full 988 crisis system, I'll share a little about the National Suicide Prevention Lifeline, and the role it'll play in 988. The Lifeline is funded by SAMHSA, the Federal Substance Abuse and Mental Health Services Administration. It offers free, confidential support 24/7 through a network of 170 local crisis call centers all across the country. And when you call the 10-digit Lifeline number, if you press 1, you're routed to the National Veterans Crisis Line. If you press 2, you're routed to a Spanish call center network. And all other calls get routed by the Lifeline to their local crisis center. And if that local crisis call center is unable to answer in time, the call is rerouted to the Lifeline's national backup network. With 988, the same system will be used to route and respond to calls. The difference is that many more people may be making calls, and we expect the network of call centers to expand to handle not just more volume, but a wide range of mental health, substance use, and suicidal crises. I just spoke about the National Lifeline and its role, and now I want to talk about the role of call centers at the local level and the rest of the 988 crisis response system. We're really talking about 3 core components or pillars: call center hubs, mobile crisis teams, and crisis stabilization programs. State or local 988 call centers should have well-trained staff and be available through phone and text and chat. They should serve as hubs that have strong connections with other emergency systems and with local mental health and substance use provider networks. They should be able to dispatch mobile crisis teams and ensure connections to other services, including crisis stabilization. And really robust call centers, like the Georgia Crisis and Access Line, have more capabilities, like master's level clinicians who are able to do mental health and substance use assessments. They have the ability to schedule urgent outpatient appointments while people are on the phone. And they have electronic bed inventories so they can tell where there's open crisis and detox beds. I know some of you are probably thinking, I want to know more. Well, sign up for our next webinar in this series because we're going to have the Georgia's Crisis Line folks on to share more. And I want to say that if Georgians have this, why shouldn't you? And that's, frankly, why we're doing these webinars, to showcase what's possible so you can fight for the system you deserve, not what you're necessarily getting. And the next part of the system is mobile crisis teams. Mobile crisis teams are often staffed by a mix of clinicians and other mental health staff, including peers. Mobile crisis teams, as the name implies, travel to where people are at. They help assess and stabilize, de-escalate the situation, and may help a person into a higher level of care or other services and supports. Mobile crisis teams are an essential pillar of the system because people who are experiencing severe symptoms of mental illness or substance use disorders often need an in-person response. There are many different models of mobile crisis teams. Co-responder models, for example, include both mental health staff and law enforcement officers. And in a little bit, you'll get inspired hearing from Ebony, who'll talk about the CAHOOTS model, which is a mental health only mobile crisis team. The third pillar of our system is crisis stabilization. Crisis stabilization can refer to multiple options. An increasingly common option is a crisis stabilization unit that's in a living room-like setting and provides observation and stabilization help for under 24 hours. But for many people, there'll be need for other options like short-term crisis facilities, crisis residential care, inpatient hospitalization, or other intensive services. And really strong crisis stabilization programs have peer supports. They have detox facilities. They help people get the right follow-up care. And they accept all police referrals with 0 rejections. And some have dedicated areas for first responders to drop off an individual and turn around within 5 or 10 minutes. Again, we'll show you what this can look like in one of our upcoming Help Not Handcuffs webinars. And now I want to share how this might look in a real-life situation. I'll share a version of this. When my son experienced a psychotic episode a few years ago, a friend was able to call a dedicated behavioral health crisis line for me. But with 988, it would be much easier to remember and dial. My son was delusional and threatening at times, so this was not a situation that could be resolved over the phone. In my case, the crisis line dispatched a mobile crisis team that included CIT-trained police officers, but they took a back seat to the behavioral health clinicians. The lead clinician established a rapport with my son, and after spending time with me and with him putting together all the pieces, going through the house, she said, "I'm hearing, Alex, that you haven't slept for days and things are getting kind of intense. I'll bet you'd really like to get a good night's sleep. Do I have that right?" And he said, "Yeah, my head hurts and I just want to sleep, but I can't." And she said, "The doctor at the hospital will definitely be able to help you get to sleep and help your head start hurting. Does that sound okay to you? Are you willing to go with me?" And remarkably, he said, "Yeah, I'll go. I want my head to stop hurting." Now, the next step in his journey was a crisis stabilization unit, which after 23 hours moved him into a psychiatric inpatient unit because he was still delusional and paranoid. And while I can't say the hospitalization and the rest of the journey went well, the crisis response piece did. And this is what we want across the country, because under different circumstances, my son or anyone we know with serious mental illness could easily have ended up in jail or worse, shot and killed because of their behaviors. We're grateful that momentum is building everywhere rapidly for a mental health response to mental health crises. But it will take advocacy and funding at both the federal and state level to realize this vision. And NAMI and our allies have been working with Congress to help states with funding streams that can help them plan and build crisis services. Last December, the fiscal year 2021 budget at the federal level included a 5% set aside in the Community Mental Health Services Block Grant for this fiscal year, dedicated to crisis services. It also included emergency funding for SAMHSA that can be used for crisis services and a $5 million increase to the Lifeline. And in this month's American Rescue Plan, a key provision was the aptly named CAHOOTS Act provision. This lets states tap into an increased federal medical assistance percentage, or FMAP rate, of 85 percentage points for Medicaid programs that want to incorporate mobile crisis teams. This creates a huge financial incentive for states to adopt mobile crisis. And that provision also included $15 million in grants for states to plan to implement or expand mobile crisis teams. Now, these were important wins and provide opportunities for states, but they're not enough. Significant and stable federal, state, and local funds are needed to expand the capacity of the Lifeline network to serve the increased demand and scope of services, to implement and expand mobile crisis teams, including specialized teams for children, and to develop crisis stabilization programs that truly serve the needs of people with severe mental health, substance use, and co-occurring disorders. So what's next at the federal level? Well, right now, SAMHSA is working on a required report to Congress on estimates of costs for implementing a 988 crisis response system, and that's due April 17th. This report will help fuel future asks for state and federal funding. And in the meantime, NAMI and our partners are beginning work to expand federal funding for the Lifeline, for mobile crisis teams, and for crisis stabilization in the fiscal year 2022 federal budget. And with that, I'll turn it over to Hannah to share what's happening at the state and local level. It's a lot. Hannah?
Thanks, Angela. The federal action Angela discussed has created an opportunity for states to transform crisis response, mandating that this 3-digit number, 988, be available for a broader scope that includes mental health crises, and that it be available by July 2022. Congress is providing growing resources to help states drive more robust crisis care, which Angela just went through, like mobile crisis teams. But congressional action alone is not enough. states are going to have to act to make sure that comprehensive crisis services are available when someone dials 988. And frankly, whether states act or not, 988 is going live by July 2022. The question really is, what is going to be available on the other end of the phone when someone dials 988? Are they going to be able to get the help that they need? So far, there have been 17 states that have introduced legislation related to implementation of 988. And frankly, no two bills look alike, and that's because each state currently has very different models and systems in place for crisis care. Late last year, early this year, the National Association of State Mental Health Program Directors created model legislation, which was influenced with feedback from NAMI and other mental health organizations, to really act as a roadmap for states on what to consider and address in legislation. It includes a few things. First, it specifies requirements for 988 hotline centers and crisis response services, including statewide mobile crisis teams and crisis stabilization programs. It also enacts user fees, which are a monthly surcharge on all phone bills, to ensure 988 has a sustainable funding mechanism. And along with that, it creates a trust fund to collect and protect that 988 revenue and prevent those funds from being used for non-988 system related use. It's common that when revenue comes in, it's diverted elsewhere, and it's really a mechanism to protect those funds. It also designates a state oversight body to oversee 988 implementation and ensure that all state entities are cooperating to fully implement a crisis response system. And in some cases, it's even indicating who should be involved in that oversight body, like peers and family members. And finally, it ensures interoperability between 988 and other state emergency systems like 911, so that these systems can communicate with each other in a crisis when it's needed. So I mentioned user fees, and I want to talk about that a little bit more. Unfortunately, we all know that there is always too little funding for mental health services and supports. The federal legislation that was passed last year specifically allows states to impose a user fee. Again, that's a monthly surcharge on all phone lines. And it is clear that these fees can be used to route calls made to 988, so route them to that national network and those call centers. But it can also be used for, quote, personnel and the provision of acute mental health crisis outreach and stabilization services. So basically, Congress opened the door that these funds, if states impose them, can be used to fund not just the operations related to the 988 number, like a call center, but that they can also be used for services needed on the other end of the phone, like a mobile crisis team or crisis stabilization. And that's really important. It gives states an opportunity to introduce a new funding stream to support better crisis care. And frankly, that's a really rare opportunity. It's the first truly new funding stream for mental health since the Affordable Care Act passed 11 years ago in 2010. And these fees are really minimal. They range from 8 or 10 cents a month to $1 per month in one state. And if you look at your phone bill right now, if you pulled it out, you'll already see a fee for 911 on most phone lines. And these fees range so much because it's really dependent on what services states are requiring be available in their legislation and what services the state already has in place and how it funds them. The important thing about this is that the revenue for these fees is really steady and consistent, and that's different than a state budget allotment. State budgets are approved every single year or every other year, and they're always under threat, especially during downturns in the economy, which is often when crisis services are needed even more. In reality, it's probably going to take federal funding, state general funds, services that can be billed to Medicaid and private insurance, and these user fees together to make a robust crisis care system possible. We really need all of these things to put the services that have too long been underfunded into place. So I won't spend too much time going through the details of all of these pieces of legislation, although I'm happy to talk to anyone on the side. But this is really to give you a flavor of the legislation that's out there and how it differs. I will note that in the last week, Utah and Virginia's bills have been signed into law. Both of these have either a limited or no user fee, but they have companion bills that fund more robust crisis services in their state. Washington State's bill is one that's moving through the legislature with great bipartisan support, and it has a graduated fee structure. So that fee increases over time and it requires comprehensive crisis services. California and Colorado both allow a state agency to regularly assess what annual fees are needed to fund the estimated costs for services up to a capped amount. Those fees couldn't be endless. There's a capped level of how much they could be. And we think that that mechanism to regularly review the fee amount, like in California and Colorado, is helpful because at the end of the day, we really don't know what the demand is going to be for 988. We know we have the existing calls to the National Suicide Prevention Lifeline and mental health related calls to 911 that will now be routed to 988. But there will also be people who are frankly afraid to call 911 for fear of a law enforcement response. And as 988 becomes more known to the public, there will also be people who just didn't know where to turn for help that'll be calling that 988 number. So it's hard to estimate right now what the cost of a 988 system will be because it's going to depend on what that demand looks like. So it's really critical that we have the ability to readjust to meet that demand and actually help people on the other end of the phone. Everyone has a role to play in 988. First, get engaged in your state's planning discussions. Almost everyone is a stakeholder, from peers and family members to teachers and mental health providers to law enforcement officers. Every single one of those individuals has important perspective to add to the conversation. Most states currently have a planning committee for 988 implementation. There may be an opportunity to join that conversation and influence what's being built or being reimagined in your state right now. Aside from that, your local community also has an important role to play here because local communities play a major part of implementing a crisis response model. If you look at most CIT programs or co-responder models, they're often initiated at the local level. And whether your community has an existing system or is building a brand new one, just make sure that what they're doing is tying into your state's larger 988 network as that effort moves along as well. I also encourage you to connect with your state legislators and tell them why a crisis response system is needed and how it would impact you or your community. If there's legislation that's introduced, follow it to see if there are opportunities to testify and share your experience and perspective. Personal stories matter, and telling them that a mental health crisis deserves a mental health response is important for them to hear. And I strongly encourage you to recruit others to share their experience with policymakers as well. Finally, as you're doing today, learn about the models that are out there. You can't build what you can't envision. Every state or community is at a different point in the crisis care that they have available. You may only have a law enforcement response right now and may be looking to implement a crisis intervention team. Or you may have a great CIT program already in your community and are now looking to implement a co-responder model. Ultimately, it's our hope, as I hope you've heard today, that we can all work toward limiting law enforcement involvement in people and in helping people in a crisis. This isn't going to happen overnight. It's actually going to take years to fully implement a system we want to see, but every step along this continuum is an important one. And today you're going to get to hear about one model, the CAHOOTS program, that has been a leader on mobile crisis teams. So before we leave, I just want to share Angela's information and my information. You can reach out anytime with questions that you have. You can also learn more about NAMI's work at nami.org/advocacy. Now, I'm pleased to introduce Ebony Morgan, Program Coordinator for the COOTS program, to tell us more about their model. Ebony?
Hi, I work with CAHOOTS. I am the Program Coordinator, and CAHOOTS stands for Crisis Assistance Helping Out on the Streets. In Eugene and Springfield, Oregon, which are neighboring cities, when someone calls 911 or the non-emergency police number for help with a nonviolent and non-criminal situation, CAHOOTS can get dispatched instead of police. This is especially true if the call has a mental health or a substance use component. Eugene has had this alternative to a police response in place since 1989, so over 30 years at this point. We're part of the public safety response system in our area, providing a unique alternative to police in times of crisis. We operate in unarmed pairs with an EMT and a crisis worker, and we respond to calls all over the city in our van, offering crisis intervention, support, and resources to the community members that need it. whether they call for themselves or someone calls on their behalf. For people unfamiliar with our program, it can be really tricky to describe how exactly we operate and what exactly it is that we do. And the best ways that I've found to explain it are by providing some examples. So we consistently start our shift making sure that our van, which is a large kind of cargo sized van, but we have it set up to be able to transport, is stocked with basic needs and supplies, medical equipment, and other gear in general that might be useful to the clients we encounter or ourselves. Our van is outfitted to transport clients as well as hold our equipment. So once we're ready to start the shift and we know we have everything that we need, we use the police radios that we carry to alert dispatch that we're ready to take calls. Once they know we're ready, they're going to give us a location of our first call. So we'll drive from our office over to that address. They'll give us the details of what we're going to as much as they can, but it's usually very little, which is better because we show up without an expectation. We can go in open-minded and ready to be helpful in whatever way is most effective. So once we get there, we'll tell them that we've arrived through the radio and enter the scene. And from there, a call can look a lot of different ways depending on the nature of what it is that we're approaching. Let's say in this first example, maybe this call was a concerned passerby who wants someone to check on somebody who they know sleeps outside in their area. They see them every morning and they usually get up and move by 8 a.m., but they haven't moved yet and it's noon. So let's say we check on them. We approach that person and we say, hey, someone noticed that you hadn't gotten up and moving today and they were just wanting to make sure you were okay. And they tell us they haven't moved because they hurt their foot the night before. They accidentally cut it on something and they don't want to go anywhere to see a doctor, but they would like someone to look at it. They just really have had bad experiences at the hospital and are just not in the mood to do that. And maybe they're really anxious about what a foot injury means when they're unhoused and they need to be able to move around. We conveniently have a medically trained team member who can do a medical assessment and provide basic medical care. And perhaps on this call, it's as simple as cleaning and wrapping a small wound on an otherwise healthy human in an effort to prevent an infection. Our crisis counselor, while they take care of that wound, can keep that person occupied and provide counseling for what we'd call situational anxiety. And once done, the shift partner who was doing the wound care can educate the client on the signs that you should watch for if something started to appear infected or causing a further problem that would warrant seeking further medical treatment, which we could help you connect with in the future. So we build that rapport, we help them understand what it is they should watch for and try to prevent any further complications. And now the client gets to feel some relief and can move on and get back to business as usual. And once we finish with that client, we're going to go back to our van, we're going to sanitize our gear, we're going to hop back in and let dispatch know that we're done with that call. And if appropriate, sometimes we'll let them know that sometimes we're sent if a business is like, I don't want this person sitting here, but I'm not trying to get them arrested. I just need them to do something different. We'll let them know, hey, we're done, we're clear. They decided to move along, this is handled. So we'll let them know they don't need to follow up in any way and let them know we're clear for our next call. And let's say while we were on that call, because this happens, we heard that officers were being requested by a concerned family member for a client that we have a lot of experience with, but the family members don't know that we're an option. We can offer to go because we know that we have rapport with that person. We often handle those interactions with that person on our own. And if dispatch agrees that it's appropriate for us to handle it, we will drive over to that location. And say we get there and that person is feeling suicidal and their suicidal ideation is more severe than our ability to provide on-the-spot counseling can resolve. One of the options that we have is to transport the client to our local hospital that has a specific psychiatric component to its emergency room, where they're prepared for a mental health crisis. We can inform the client of that if they don't already know, and the client can choose to come with us to the hospital of their own accord. And we can't force you to. And if we can't be certain that you're going to be safe by yourself, then we really try to get you to be willing to come with us, because it's a lot more comfortable to come with us of your own choice and just ride in the back of our van than to be handcuffed and put in a police vehicle and taken there against your will. And so we try really hard to let people voluntarily choose to engage in supports. We would tell dispatch that we are transporting our client to the hospital, and then we will call the hospital and let them know that we're on the way. Similar to the heads up that they receive from medics when they're doing an ambulance transport, because paramedics will alert the hospital on the way. So when we get there, we'd hand off the client to the hospital staff and give report to the nurse and the social worker. We'd advocate for the client and maybe share what we hope the hospital can do for them. And then we'll be on to the next, just like before. There's a lot of different ways that mobile crisis intervention can look.
Ebony,
Yeah.
this is Terry. I apologize. We're trying to catch your slides up with you. We wanted to make sure we were in the right place.
I got it. We're right where we should be.
Terrific. Thank you.
Thank you. We are, as the CAHOOTS program and doing mobile crisis intervention, we're sometimes referred to as behavioral health first responders. And in principle, what that means is that we meet you where you are to provide you support. This can look like crisis counseling, suicide prevention, mediation. Sometimes we'll go out, and especially over the last year or so, when everybody's been stuck inside, people are struggling to share a space that much and get along, and it's normal. That's normal. And what we get to do is come in and we have two people. We can separate you, we can hear you both out, we can bring you back together and try to figure out what the common goals are, what are we stuck on, what can we do about it to make the rest of the day go better before it just continues to escalate into something that is now more concerning. We can provide grief counseling. So one of the things that the police department has shared with us as a responsibility is death notifications, because while we're there, we can also help you connect with the supports around you that you know exist but might forget about in the moment. We can help you try to plan some next steps. We can do welfare checks when people are concerned about others, talk to you about substance abuse, provide non-emergency medical care, and take you to necessary services. The tool we use most to do all of this is our training. And in addition to our training, we carry our med bag, which is good for basic medical interventions and wound care. We have other medical equipment in case we're the first on a scene that requires life-saving interventions, in which case we'd use our radios to request paramedics. We also have Narcan in case we're the first on the scene to an opiate overdose, because sometimes people do call us instead of other services because they trust us. So we got to be ready for whatever we're going to walk up to. One of our greatest tools and the most discussed is de-escalation, which is defined as a reduction of the intensity of a conflict or potentially violent situation. And in doing that, scene safety is always our #1 priority, which is how we have never had a serious injury or death of a team member or client as the result of an interaction. On CAHOOTS, we combine EMTs and crisis workers because we recognize that medical and mental health are equally important components of overall health. The National Institute of Mental Health reports that mental illness, especially depression, increases the risk for many types of physical health problems, including stroke and type 2 diabetes and heart disease. And similarly, the presence of chronic conditions can increase the risk for mental illness. So when CAHOOTS arrives on scene, we bring both the medical and crisis intervention perspectives, which allows us to have a more holistic approach to each call. We prioritize a client-centered approach in which we encourage people to identify their own needs and help people figure out how to best meet their needs once we've established them. We provide trauma-informed care, which means we treat the whole person. And in doing that, we consider past trauma and the resulting coping mechanisms when we're attempting to understand behaviors and treat the patient. There's no judgment involved in that. We practice regularly harm reduction, which looks like supporting policies and providing interventions that are designed to lessen the negative impacts, either social or physical, consequences associated with human behaviors and decisions. And the unarmed de-escalation is really the root of how we arrive and what makes us our own entity in combination with our mental health training. We're an unarmed and consent-dependent response. Consent-dependent means that the clients have a choice whether or not they engage with our services, and we cannot force anyone to do anything. Given that, it's crucial that we be extremely skilled in de-escalation and carry rapport and trust in our community. When people see us, they need to believe that we are there to purely be helpful. So our new staff undergo more than 500 hours each of field training and more than 30 classroom hours before they're considered trained. In our work, we also strongly believe in the responsibility that we have to advocate for the community. To quote the American Public Health Association, in order to assure that everyone has the opportunity to attain their highest level of health, we must address the social determinants of health and equity. And this is a really big ask because it involves a lot of systems working together to build bridges and support those and develop those bridges between those who have more than enough and those who do not have enough. We have to work together as a community to show all of the members of our community that we are in this to support them. Who shows up in our work is one of my favorite things to talk about because I think it's a really, really neat approach. We have an EMT on our staff, and this is the medically trained half of our two-person response team. And we have varying degrees of licensure involved, but they operate within the scope of an EMT. We have EMTs that range in level from basic to advanced, and we have nurses on our team as well that fill this role. And due to the nature of our work, our medics are also trained in crisis intervention and how to be a crisis responder in order to support the work of our crisis workers. There's a lot of teamwork and partnership that goes into showing up. With having a medical component as part of our service, one of the things that we're able to do is emergency room diversion. We are able to divert a significant number of medical calls for service from the ambulance and the paramedics and or from the emergency room and connect people with the appropriate resource for whatever they're experiencing. We can assess basic medical concerns. We can provide wound care and talk about substance use and the impact that's having on health. We can ensure that people are thriving if we notice that someone is failing to thrive, which means in general that they are not, their health is just not intact. They're not quite able to succeed. Why? What resources can we connect you to that are preventing you from getting to that place? This is absolutely a crisis, and that is a crisis intervention. If there's people who frequent certain systems, they can call us and we can help connect them with what is going to get them the best outcome for what it is that they're going through. And along with our medical component, we have our crisis workers. And we don't require a certain level of licensure for our crisis workers, but they must be eligible for QMHA certification or Qualified Mental Health Associate certification. We have QMHPs on our staff that provide supervision to our QMHAs, and some of our team members in our crisis worker roles are licensed as social workers or LCSWs. We combine these two practices extremely intentionally. As an example, anxiety can present in a lot of ways that resemble a heart issue. And I can briefly tell you about a call I had where we were called for a human that was experiencing anxiety. And my own experience has shown that sometimes you can't quite name it, but someone just doesn't look quite right. And you pay attention to that. One of the first things I noticed was that this client was very pale and appeared very anxious, but the rapid pace of his breathing didn't seem nervous. It really seemed like he couldn't catch his breath. So we talked and checked his vital signs, and out of caution, we asked if he was experiencing any chest pain, and he said yes, but I thought that anxiety made me feel that way, because it does. And this is where having both perspectives is so important. Certain conditions can mimic each other in ways that make it really difficult to rule out which is happening without having testing available. So that's what we shared. We said it seems appropriate to call an ambulance to get you to the hospital. We requested the ambulance through our police radio that we carry, and the client was reluctant to that idea. So one of my personal favorite things to do is educate the client and help them make an informed decision for themselves. You're a person, we respect your right to make choices. Let me help you understand the full scope of this choice. And once we had outlined why we were concerned, he agreed that it seemed wise to go get checked out. The paramedics came, also agreed, and they took him to the hospital that was most equipped for cardiac events. So we do work in partnership with the other services in our area to make sure that people get connected to what they need. Primarily, our closest relationship is with our local police departments. We were not designed to replace any part of the current system. We're an addition to the current structure of public safety, and we fill the gaps that police were not designed to handle, like mental health concerns or homelessness. We are not trained in law enforcement and do not have the same authority as police. We built this relationship many, many years ago, over 30 years ago. It was originally law enforcement working with self-described hippies. And the name CAHOOTS came out of this idea that we were now in cahoots with the police. It was an interesting choice to make, but what had been noticed is that the service that Whitebird, which is CAHOOTS' larger parent agency, the service that Whitebird was providing benefited everyone. It benefited the community members that were able to walk in with a mental health crisis. It benefited the police when they were able to drop someone off that did not need to be in jail, but did need some support. And over time, this partnership grew into what it is now. And what it looks like now is that I attend monthly meetings with the Eugene Police Department. And in those, we problem solve. We work together to figure out the best possible resources and how to provide them to the community together. What else we could advocate for. We put our heads together on what else will help our community members. We give each other feedback, and we try really hard to show up for the community and connect the need with the resource. Why send the people that are not quite prepared to deal with a certain thing when you could send somebody who gets it? Certain situations are not necessarily appropriate for us. Since we're unarmed, we don't have lights and sirens, and if you don't consent to engage with us, then we don't get to make you. So if it's a violent scene and weapons are involved, if it's a criminal situation, you're looking for some kind of criminal reaction, that's not us. If you're requesting law enforcement duties or it's a really serious emergency medical situation, we might be able to participate and help with some of the other pieces. We can usually find a way to be useful, but it's probably not our show. But there's often an overlap, and we will respond alongside police and or paramedics. And this is different from what's typically referred to as a co-response because we're arriving separately. We're bringing each of our own strategies and protocols to a call, and we're working together to achieve the best possible outcome, which for us is often jail diversion. Instead of having to go to jail for public intoxication, maybe we can take you to the sobering center. Maybe we can help you come out with a better plan than what's going forth right now. If someone is exhibiting any signs of a cardiac issue, we're on scene, we're gonna ask for the paramedics to respond, to do an EKG and check the heart rhythm and make sure that either we're okay to transport or that they need to. Because we can't provide medical interventions in the back of our van during transport, some things aren't appropriate for us. And so what we do is work with these partners to figure out in what way we can best meet the situation's needs. Part of our working so closely with the police departments is that we are dispatched by the same dispatchers. And this is a really crucial piece of how we operate and how we stay safe, how this work gets done. CAHOOTS calls come into Eugene's 911 system or the police non-emergency number. The call takers and dispatchers are trained to recognize nonviolent situations with a behavioral health component and route those calls to CAHOOTS. If the person is requesting police, but the situation is appropriate for CAHOOTS, the call taker can offer the CAHOOTS response. And this is how some people learn about our service and get familiar with what we do. The call taker takes the details like where it is, what's the name, who are we looking for, and what's being requested. And then the calls are ranked by priority, and dispatch will contact us via our police radio and provide us the details. We also use our radios to communicate back to dispatch if we need any kind of backup, police or paramedics, or if we're transporting somebody, and other updates as necessary. one of the things we're asked a lot is why not a co-response, or why is this better than a co-response? And I can't say that exactly, right? But what I can tell you is why we aren't one and why we don't need to be one. How do we do this in a way that is different? This slide outlines that there were more than 20,000 calls that we were associated with in some way. It doesn't mean we responded to every single one of these calls, but when the call came in, maybe they asked for us, maybe we responded. But out of these 20,000 calls, we asked for police backup after arriving 311 times, which is not a whole lot. And this is for a lot of various reasons. One is that the dispatchers do a really phenomenal job of making sure that we're responding to things that are appropriate for us. Others are that de-escalation is a lot easier when you're non-threatening. This is what I might look like when I'm on shift. I don't wear makeup, but I'm gonna be casual. I'm gonna have my hoodie on. Just says CAHOOTS, and that's what I have. And everything about my body language, everything I say, I'm very mindful that we appear non-threatening and we appear just as helpful as our intention is to be. The other piece is that a mental health crisis is not inherently dangerous. It doesn't mean that we are at risk just because someone's having a mental health crisis. Like feeling suicidal and homicidal are not the same thing. We maintain a lot of scene awareness. We communicate clearly with our partners. We have our radios just in case we do need some further support. And we really trust our intuition and really consistently prioritize constant de-escalation and just keeping scenes calm and controlled to the best of our ability. The tools we have are very, very valuable, the things that we prioritize and use, but we don't pretend that they're appropriate for every single situation. Our funding, in Eugene, we're funded through the city, and that is via a contract that we have with the Eugene Police Department. So our agreements of service are negotiated between myself and the Whitebird Agency and the Eugene Police Department in that city. And some of the funding comes from the police department and some of it just goes through the police department to come to us. In Springfield, the neighboring city, it's a combination of funding from the county and from the Springfield Police Department, also through the city. In addition to that, we have a little bit of wraparound funding from a local Medicaid provider for the healthcare system diversions we do, because they recognized that the ability to divert people from the emergency room saves a lot of money on the other end. It is not a primary source of funding, but it's a neat addition. When you take a hard look at the function of public safety as we know it, it's really apparent that our system is designed on many levels to be reactive instead of proactive. And this is also true for our healthcare systems. Recent changes have pushed some preventative medical care to be more accessible to those with health insurance, but we have a long way to go towards true accessibility. As a nurse who's passionate about public health, I often dream about what it would take to create an ideal situation. What does it look like when we have needs met? And there are a lot of things I think, but what if, for starters, we met the needs of our community members proactively and people simply didn't find themselves in a crisis over basic needs? Within CAHOOTS, something we often say is that we are only truly as strong as our community resources. If you're having a crisis that requires a resource to resolve, we are not magically able to be that resource. We can help connect you, but if it doesn't exist, we're limited in what we can offer. If you're having a housing crisis and we don't have shelter options for you, we can help you stay outside, be slightly warmer or maybe a little more dry, but we can't resolve the true crisis. We can reduce the harm, but we can't solve it by ourselves. If you're too intoxicated to be safe in public, we can transport you to a sobering center. But if we don't have one, our options are extremely limited. We're torn between helping you make it on the street despite being unable to fend for yourself and transporting you to the emergency room even though you don't need life-saving treatment. And neither of those things is particularly appropriate. So with that gap in a resource, you've got to just make the best choice with what you have, which we're very good at, but it's better when those needs can be met. So we're extremely grateful for the network of community supports that exist in our area. We're also acutely aware that it's not quite enough. CAHOOTS is a really inspiring model to me, and I really enjoy talking about it. It doesn't pretend to be perfect. We don't pretend to answer all of the questions out there about what does it mean to show up for the community in a better way, but we are something different. And if there's anything about this model that jumps out at you or speaks to you or would make sense in your area, hold on to it and advocate for it. And I really appreciate your time today.
Thank you to each of our speakers. That was a superb summary of 988 and one brilliant community response. Let's take some questions. The first question is for the NAMI leadership. Let's do a little more detail on the funding of 988. Is that fee per phone, per user? Is it ongoing? Is anybody resisting it? That sort of thing. So it's about the stability of 988 and the funding that would attend to it.
That's a great question, Ken, and I'll take that. And Angela, feel free to jump in. So it would not be per call, it would be for everyone who lives in a state. So if a user fee got implemented, it would appear on all phone bills. So a mobile phone bill or a landline phone bill. And it would be something that would be long-term. So it wouldn't just be for a year, it would be long-term. And like I mentioned, if you looked at your phone bill right now, you already pay a small fee every month for 911 services. And it's likely higher than what you will see for 988. But this is a way to get these programs started and provide those stable resources to make them available. There is some resistance because it is an additional fee on residents, but by doing it this way, it's a very small amount spread across the entire population. No one knows when they're going to be in a mental health crisis. No one knows when they're going to need a service like this. It's something that makes it available for the public good for everyone to benefit from. And Angela, I don't know if there's anything you'd add there.
No, I think you captured it perfectly.
Second question for the NAMI team. What happens if you dial 988 and you don't live in Eugene, Oregon, or another remarkable place? What is the expectation for your outcome?
That's a great question. So this is both the promise and the reality of 988. So depending on where you live, you may experience a different set of services when you call that number. What we're hoping is that across the country, as people become aware of what is possible, they'll advocate and make sure that their policymakers start funding the kind of services that we're talking about everywhere. But the reality is, if you live in a place where there are no mobile crisis teams, there won't be one to dispatch to you if you call 988. And that's why everybody's advocacy is so important. Because while we have great services in a lot of places around the country, we also have so many places where these kind of services that you've heard about today simply aren't available.
Thank you. Some questions for Ebony at CAHOOTS. Many questions for this remarkable program. Let's talk a little bit about the kind of de-escalation training people get. Is there a certification in that? Like, how do you know that I have this epaulette or skill set?
There is a little bit of an it factor component. And the people.
What did you say? I'm sorry, there's a little bit of? There's
a little bit of a component that we can't quite put a finger on, right? There's ability to respond to something and remain calm, control your own emotional response in regards to someone else's. And that we can, if you have that, we can teach you from there. If you can stay calm in a crisis, we can support that. Within the hours and hours of training that we provide, the hundreds of hours, most of it, aside from the classroom chunk where we break down the specifics, outline the expectations, we'll give you some of the tools for de-escalation that we know and that we have. It's field training. You ride along with a fully trained pair and watch those skills, observe those skills, and then practice those skills with the people next to you that can make sure that it's being implemented safely and going well. We prioritize letting people practice because we believe it's the best way to really hone that, in order to control your own nervous system response, to really be able to stay grounded in those high stakes situations. You just have to practice it. And it's safest to do that with people around you that are skilled in it and can support you in that. So we provide mostly on the job training, and we don't have a certificate out of our training that we provide for folks.
Okay.
It's just our job.
It's just part of the culture and supervision.
Precisely.
Do you then meet and process how that call or visit went after each one? Like, what is your kind of self-learning component to this, Ebony?
Yeah, we have a debrief process. And often after, especially during the training process, after each call, we get back in the van. And that's kind of our zone between calls where we get to sit in there, get to the next one and talk about it. And that's where we can provide feedback or make positive observations and say, this is what went really well. This is what might work better. For me, one of the first things I learned is that I'm sitting in on a screen right now, but I'm 6 feet tall. And I have a very serious face sometimes. And so if I stand in front of you and just am kind of uncomfortable and I'm just here like this trying to listen to you, it might be really intimidating to you. And I don't feel that way. I'm just kind of nervous. I don't know what's going on, but it looks intimidating and I can't de-escalate you if you're scared of me. So I learned to soften my shoulders, step back a little bit, and make sure I'm on whatever level you're on. If you're sitting down, I sit down. If you're on the ground, I'm going to kneel with you. Like we're going to figure out how to be non-threatening to you primarily. And that's individual based. And that conversation where I learned about my own body language was in the van after a call where we just talk about it. And they say part of what might've made them uncomfortable is that, you know, you're up here and they're down here and you've built a power dynamic already.
Right. One of the questions is about your relationship to the police. The one question is, are the 20,000 calls you get not now going to the police? So do they love you because you are saving them for many calls? And I think a different question is, how does the culture of the police department and the culture of CAHOOTS integrate?
Perfect.
So the two questions, one is the numbers of calls, and are you taking a workload off of them so they can do their thing? And then how do the cultures fit together?
We absolutely are. It's tricky to quantify fully because calls come in and we respond, and sometimes then we call them. Sometimes they're on calls and they call us. They say, this is not something that we feel like we can deal with. This is mental health and we should get CAHOOTS in here. And so we'll show up then. We do our best to track those, but we do take a significant load of crisis-based mental health calls off of our local law enforcement. And when we show up on a call that they've asked us for, I always hear, thank you so much. I'm so glad you're here. I don't know what else I would have done. And when we call them because we need them, it might not be particularly often, but when we do need them, we need them. And so we are grateful that they arrive as well. There's a very mutually supportive dynamic there. We save them some time and some energy and some resources and save people in the community from getting a response that isn't appropriate or informed enough to meet those needs. And then we also lean on them as well. There's a mutual respect. And so that ties into what this relationship is like. And there's a respect for each of our own pockets. There are many things that they do that we do not do. And it's really tricky to quantify in dollars how much we save them, for example, because a lot of the things they do aren't just street hours. They go back and they have to do their research or do their investigations or whatever they're doing. I'm not the expert, but they do a lot of things that we don't have to do. We just show up, meet you where you are, help you in that moment, and move on to the next. So it's tricky to do a direct comparison, but even though the work we do is different, our common goals are how do we give the best resource to the community that we can? What is it that we can provide and how do we provide it to the best of our ability? And we might have very different ideas about what that looks like and how we're going to achieve it, but we can work together to figure out where each of those things fits. And that's where focusing on those common goals is where we're able to get past some of the political tension, past some of the differences of opinion, and get right into, this is our community. We are all involved in this community. So how do we support it to the best of each of our abilities, and what can we bring together to support it together?
A question comes up about the community. How many of the people that you interact with do you already have relationships with? That is to say, how many of them are brand new, and how many of them are, well, Mr. Smith, you know, I know we saw you a couple months back, and you know we took you to A or B.
Yeah.
And now we're checking in again. Could you define that a little bit?
Absolutely. I'm not going to pretend to have the numbers on that in front of me. 'Cause
No, we're good. We're good. Ballpark.
but I can say I think that we do ultimately, through the nature of mental health, see people repeatedly, whether that is, you know, we've met you a year ago and now it's a different team, different situation, or we see you lots of days. And that's all right too. Just because you're in a crisis now does not mean you will not be in a crisis tomorrow. There's no cap on that. But we do, I think they're equally important pillars of our work of meeting new people where they're at and continuing to provide crisis intervention for folks that we're very familiar with. The familiarity can play to our advantage or our disadvantage depending on the situation. So neither of those is better.
Can you develop the advantage and disadvantage idea of being connected to the people you're serving?
Of course. Sometimes, but we can't give people what they want all the time. We are not miracle workers. We're just humans. We're humans that care about the other humans in our area and have a certain skill set that we can apply to help you have a better day. But sometimes that doesn't mean that we can meet the need that you're asking for. And sometimes the way that I do crisis intervention isn't going to be your favorite. You might not like me, and you might call for CAHOOTS and you might get me. And that's how that'll be. So, you know, if you are meeting us for the first time, you don't know what to expect. We have the world as our oyster. We can figure out what to do. If we're meeting you for the 20th time and you already know that we can't do X, Y, and Z, which is what you really want,
right?
You might not be thrilled to see us.
You can't give them an apartment.
Right. And let's just notice the need for housing resources. Always willing to do that. No, I can't house people. I don't have access to that. So that is definitely.
Of course. Do you work with families is another question. And how do you think about the family engagement in this process?
We certainly do. Family networks are so strongly connected that there's bound to be some miscommunications in there or some barriers in there with one another, and we can show up to try to support that. What we always try to do is figure out what, to the best of our ability quickly, what is the root here and how can we kind of make some space, get to it, bring it back together. And sometimes that looks like just informing people of what resources are available. It looks like what's really happening here is a fundamental communication breakdown. You're saying this and you're wanting to hear this, and they're really kind of similar, but they're just not meeting in the middle. We are not ongoing therapists. We are not ongoing providers. We are immediate intervention. So what we can do is bring it down, talk about ideas. Have you considered talking to somebody externally to try to figure out how you can meet in the middle? And a lot of people have a lot of stigma around that. We're like, we don't need to go to therapy. It's not, you know, we have this under control. Well, yeah, of course you do. But what if we were all a little bit better? What if we all practiced a little bit of skills? So it's connecting people with the resources that exist and informing them on what they're really about so that we can promote that family component. We do engage with a lot of families, and I will say that I think adolescent crisis response is also extremely important, and it is its own unique entity to such a degree. Each of those interactions with children is so important because you're framing how they're going to see the rest of any kind of professional intervention forever. That it does kind of deserve its own response, in my opinion. We do the best we can, and I think we're decent at it, but like, it's really very specific. I would also advocate for that.
There's a question for all three of you. Funding for this model. Ebony described kind of local, county, police. Sounds like there's a lot of threads pulling this together. So, you know, let's say I live in a different town in Oregon. Let's say Salem, right? How far is that away, Morgan?
That's going to be about an hour drive.
Ebony, sorry. An hour drive. So an hour away, Ebony. This program probably does not exist. Right?
Yeah,
right. So how would people in Oregon advocate for funding for an analogous program an hour away? You have the resource in Ebony and her team right there. the how-to, but the funding piece, is it going to be localities? Would it be statewide? How might you think about that? So probably this is Angela and Hannah. What's the advocacy for the NAMI community on this piece of funding a program akin to Ebony's program?
So I think it's a little bit of all of the above. You know, as I mentioned, you have communities like where we have CAHOOTS that have really implemented this robust system, but it's not statewide. So local communities have a lot of power, but local communities are also very limited in the resources they have available. And states can allocate resources and mandate that these services be available. And we are seeing that in a number of states. Colorado, for example, has statewide mobile crisis teams, but they also need more. And, you know, I think most states that have it probably need more. And we're advocating for federal funding because states are in a really tight budget environment, especially right now in the wake of COVID. And so funding new services is going to be particularly difficult, not impossible. And we are urging NAMIs and our mental health advocates to fight for that. But it takes a little bit of all of the above. And some of the services are billable to insurance, but certainly not all of them. And we need additional funding from the local, state, and federal level to kind of work all around that and kind of connect all of those threads. And certainly connecting with partner systems fills some of those gaps as well. So, you know, I think for a local community looking at this, it's talking to your local leaders, but also connecting with statewide organizations and state agencies to see where they are to provide resources for this in communities that where it doesn't exist already is a great place to start.
Angela, this might be for you. The Biden bill, you know, has billions of dollars going into mental health, which, as you have taught me, is a novel first letter in front of the word illion, right? We used to live with millions when we were lucky. A question that comes up is any of that funding likely to be able to create more resources like CAHOOTS?
Absolutely, we think so. So some of these dollars are starting to flow to states from SAMHSA, the Substance Abuse and Mental Health Services Administration. And some of the guidance that they've been giving states is that crisis services is an acceptable use of some of these grant funds. So this is an opportunity for people who want to reshape crisis systems in their community to talk with their mental health authority in their state about what resources are available and how can they tap into those to actually create what they want to see in their community.
So this is a big opportunity for advocacy and engagement, it sounds like.
It absolutely is. I will caution, though, that the kinds of funds that we have now are significant, but they are one-time-ish funds. We got funds at the end of last year and also this month with the American Rescue Plan. Those can be used over time, the American Rescue Plan dollars, but not forever. So you're looking at a relatively short time span to kind of build programs up. And that's why we're working at the federal level to try and get more permanent funding streams, like satisfied in the block grant. We want that to become permanent so that states can count on those dollars every single year to come in and help support. That's why we were thrilled to see the CAHOOTS provision in the American Rescue Plan for Medicaid funding. So states choose those individuals who are covered by Medicaid. There could be a Medicaid funding stream to cover those mobile crisis services and at a very high match rate, which basically means that for every dollar a state puts into their Medicaid system, they can get several dollars back from the federal government for that service. So again, it's all about braiding together funding. And I think what you've really alluded to here, Ken, is the fact that we don't have a nationwide funding infrastructure for crisis services for mental health crises. And that is what we're trying to knit together here. And the more diversified the funding stream, the more stable it is. And that's why we talked about the user fees. And one nice thing about user fees is they tend not to fluctuate in the same way that state funds and local funds can. So state budgets, go up and down depending on the economy in the state. User fees tend to be much more consistent.
Interesting.
A nice stable piece that can help support the overall funding.
Thank you, Angela. Ebony, a few more questions for you. Let's talk about culture, diversity, language. One specific question about immigrants who need services and may not be citizens yet, people with language problems, challenges, people who aren't familiar with the disorganized mental health system, in quotation marks. So from a cultural perspective, how do you think about that? And how do you train your team to think about how to respect culture and learn about culture?
That's something that we are highly prioritizing right now, and previously regrettably did not put as much energy into. We were so focused on building a program that would function within the structures that exist, which was tricky. And now we are desperately bringing in trainings and embodying practices that deliberately center accessibility, equity, and how we can make our service accessible to truly everyone. There are components of our community that are really communicating clearly to us that being dispatched through our local police departments is a barrier for them. They're unwilling to call in and give the information necessary to get our service. And that's just something that we're talking through. We're talking through that with our police partners to say, this is a barrier being expressed to us. Is it possible to have our own dispatchers? Is it possible for us to have another way to do this and still work together? How do we meet this need and still provide this service the way we provide it? So there's a lot of reflection going on for us. And over the last year, there have been a lot of conversations about our different approaches and a lot of dialogue about what makes it right and what makes it wrong. And that's why I often say, like, CAHOOTS does not pretend to be perfect. We just insist that we're trying. We're trying as hard as we can. And it is my priority that we figure out how to be equitably accessible. I'm not going to lie and say that we've already figured it out, but we are trying to model a behavior that demonstrates a desire to embody that principle and make sure that whether or not we speak the language, we have translation available, whether or not we fully understand your culture, we know how to ask, we know how to engage the varying components of people's backgrounds in the way that we provide care. We are educated and competent in honoring what makes you unique, what makes your family unique, what makes your culture unique, your community, and saying, how does that influence what you want to do today? We make room for that so that you don't feel the need to tell us what that is. We're going to ask you how we can best support you. And that is true in the nature of our work, but it does take a certain amount of mindfulness to make sure that people are comfortable and know that you are safe for them to exist in their truest form. And that's the only way that you can truly reach people, is to make sure they know that they are safe with you.
What a beautiful answer, Ebony. That's a beautiful answer. It's also impressive that a fundamentally sound, groundbreaking program 30 years in is still engaging in discussions on how to get better, right? So it's not like it's a fixed model with fidelity as I'm hearing it. This is a creative, organic interplay.
Yes, and a huge component of that is that we are a collective and we are consensus based. So I might take the reins, say, on making things in our program come to real life. I'm the one that negotiates with our partners, talks about our budgets, speaks publicly because I care so much and I like it. But also, everybody's opinion carries just as much weight as mine. I don't make independent decisions. Anything we agree to do, the entire team talks about at a meeting that we have once a week and agrees to do together. So anyone's perspective, if somebody says, hey, I want to advocate for this community because this decision that we're going to make doesn't seem like we're listening or caring about them, everybody says, what? We forgot what? And is mortified and is just like, okay, great. Okay, cool. Like, let's just go back to the beginning and loop that in. And so we don't proceed with things without having all of the brains on our team participate in that and make sure that from all angles, we're thinking about the impacts that people are going to experience from decisions that we make.
There's a question about staffing, and this is kind of nuanced. So I'm going to go through a couple of threads.
Okay.
What is the vibe on the team? Are you searching for people? Do you have a lot of turnover? Do you have people for whom this is a calling? Do people get burned out? How do you nurture their self-care? So this is a question about the people doing this work, this remarkable work, which is obviously filled with challenges, and how you think about staff. Do you have openings that you can't fill? This is classic in community mental health, right? I had a doctor I couldn't fill for 3 years on an assertive community treatment team, in an inconvenient city. So I tried to cover that part-time. It was not great, right? Because I couldn't find anyone to do it. Is that your experience, or do you have people lining up who say, I want to be part of this super creative model?
It kind of depends. So part of our problem is that the work that we do is extremely unique and extremely challenging, and we may not have along the way advocated for the best situation for ourselves as employees. So focused on providing the service to the community that we didn't notice that perhaps like the compensation and the benefits of doing this work for the community are not the same as other roles that are fairly parallel and require slightly more advanced but not inaccessible skill sets. So what we've noticed recently is that we're losing people who want to step up and become nurses, or they want to step up and maybe they're like, I'm going to take all this super good experience and take it into law enforcement, because we've established and provided all of these skills, but we don't have the same fundamental ability to provide a sustainable work environment where you're going to want to stay and retire. And so that's something that since I've taken this position about 6 months ago, have been trying to figure out how to prioritize, because we should be a career operation just as much as anybody else. There's no less need for our service. It's just tricky to advocate for that. It's not impossible. So that's what I'm working on. But truly, people want to do this work, and the people that begin to do it want to keep doing it, because there's nothing quite like it if it is right for you, if it's something that makes sense to you. The people that we have often stay for quite a while. If they either not super long or a very long time is kind of what I encounter. And it's because there's just nothing quite like it. But how do we make sure the people that are doing it for a long time are getting adequately cared for so that they don't burn out, so that they're not getting tired, so that there's enough of a rotation of human beings? And maybe that looks like having similar programs in other areas. You can move around, you can try new things, you can experience different environments. We can all learn from one another. One of the tricky parts about being the CAHOOTS program for so long is that there was no comparisons to be made.
Correct.
We had to figure it out and try to make it the best it could be, existing kind of on a little island. And that's impressive, but I'm excited that other people are talking about it, because already, wow, that's a good idea over there. Let me just snag a little bit of that.
That's a great idea. That's a better way to do it. So Ebony, I hope you continue to, take care of other people, but also remember to put the oxygen mask on yourself and your staff. It sounds like you're actively working on that. Because, of course, the brilliance of this kind of model does require some kind of career construct, right? Because you want people who are sophisticated and well-trained to stick around. So I'm delighted to hear you're working on that. That sounds a little bit like community mental health, with its attendant challenges. So I want to, we're going to close in a minute. I want to ask each of our panelists, for the people on this call who want a program like CAHOOTS in their locality, or they have something that is CAHOOT-ish, but it's not actually as good as this, right? Any final remarks from each of our three panelists? Ebony, you've been talking a lot. I'll let you go last. So you get a little break, relax, take a deep breath. Hannah and Angela, for people on this webinar, they want something like this in their community. They know there's an opportunity, but how might they approach it? Or if you have other final comments. You don't have to answer my question.
Well, it's a great question, Ken, and I hope that everybody who's watching today is inspired. Ebony is a great inspiration to everyone, and I would think people would be very eager to have something like this in their communities. And I would suggest one of the main things that people can do is get to know their state policymakers and share what they've learned, share that they want to see this in their community. And it's just a little reminder that everybody's story is always right. So being able to share if you've had an experience with crisis services, and if you can very quickly and concisely convey how great it would be if there were a response like the CAHOOTS response, that can do wonders in helping educate lawmakers and helping them understand that there's really a lot of public support for moving in this direction.
Thank you, Angela. Hannah?
I would add, I know that we have a lot of or NAMI leaders, and if you're not involved with your NAMI, talk with your NAMI organization, but other organizations that care about this. So other mental health organizations, substance use, suicide prevention organizations. Also talk to your local law enforcement agency. When we talk to law enforcement, one of the first things that they say is we are not equipped to respond to these crises. They support having alternative models. And so they can be a great partner and champion to advance this cause. I'd also, I'm going to put a plug, go to nami.org/advocacy and sign up at our Take Action link, and we'll let you know opportunities to advocate for this at the federal level and at the state level too. But definitely connect with your NAMI organization if you're already not connected, and other partners who are like-minded to find out what is already happening. And if nothing is happening on this already, then join together to contact those policymakers and tell them that they need to act.
Ebony, do you have any final comments or remarks for the people attending this webinar conversation?
Absolutely. I think that Hannah and Angela spoke really gracefully to the steps that you can take and the people you can contact. I encourage noticing that it's all around demonstrated and seen to be beneficial for community members, for the current existing systems, and for the folks that want to step up and do this work. We work together, we work positively because there is a gap. It's not taking anything from anybody. It's not putting anybody in positions that others aren't already being put in. It's just meeting a need with an appropriate resource. And the chief of police in Eugene and I have conversations all the time about meeting the appropriate need with the appropriate resource. It is not controversial, it is mutually beneficial. And I always remind people of that because it can be so polarized, but it does not have to be. It's fact, it's reason, it's noticing a need in all of our communities and stepping up to embody it. Find the thing. There's so many components of this that matter to each of us individually, whether it's one diagnosis that stands out to you from experience you have, or a trauma that you've experienced in one of these systems, or just something you've learned about. Whatever makes you a little fiery, whatever makes you be like, we need to deal with that. Think about it, read about it, and carry that energy forward and make other people think about it and make other people read about it and just advocate. That's the best thing any of us can do, is just find the thing that lights our soul on fire and say, I care about that, and I'm going to try to make a little bit of difference and make somebody think about it. And if we all do that a little bit, the people that are making decisions are going to hear it and they're going to have to do something about it.
Ebony, we were so delighted and honored that CAHOOTS, the gold standard, was going to participate in our conversation, Help Not Handcuffs. Meeting you and listening to you has just warmed my heart about your attitude and humility about trying to work this problem and to make it better. So Ebony Morgan, Angela Kimball, Hannah Wesolowski, I want to thank you for this tremendous panel. And I want to turn this over to Dan Gillison, our CEO of NAMI.
All right. Well, thank you all very much, Ebony, Angela, and Hannah, and Ken. I really appreciate this overview and what you shared. And Ebony, as you said, it's about the mutual benefits. And, you know, it's almost getting that passion and excitement of just speaking to people and say, did you know? Did you know there's going to be an alternative to 911? Did you know what that will mean to your community that you live in? So now, with that said, let's look at help and handcuffs, not handcuffs, going forward. As we mentioned, this is a series, so we will have an additional community model or models that we will share with you on Thursday, the 22nd of April from 4 to 5:30 Eastern Standard Time. And then part 4 will be implementing a new system, and that'll be on Thursday, the 20th of May at the same time. And you can register for these sessions at NAMI.org/asktheexpert. With that said, we really want to close out by saying that, you know, the Ask the Expert is an informational webinar. And so this is just a disclaimer in terms of what it is, what it's not, and what we hope you can get from it. And the bottom line, we can do our work and what we're doing on behalf of communities across the country because of donations. So we always like to reference the opportunity to donate to NAMI, and you can do that at NAMI.org/donate. Now, all of this work that goes into bringing these productions to you is in front of the curtain, but there's a lot of work that goes on behind the curtain. And there's a production team that makes this look seamless. And just like to recognize the team. That's Jordan Miller. She's the lead producer and really constructs this and handles all the technical issues and the overall flow of the webinar. Dr. Terry Brister does the welcome and stages everything for us in terms of muting, unmuting, and how to actually put questions in. And Jessica Walthall also assists behind the curtain with collecting the questions. And then Christina Bott also helps with the technical support and making sure that we have backups, so we have that quality assurance. So this team, Jordan, Terry, Jessica, and Christina, is extremely important to us. And like all of you all, we're excited to have you with us. In closing, the other thing I wanted to mention is that the NAMICon, our virtual, or our convention, excuse me, will be virtual for the second year. It's going to be on the 27th and the 28th of July. Registration will open on the 5th of April. And for students, it's $10. And for NAMI members, it's $15. And for non-members, it's $25. We really have some exciting things we're going to be bringing to you. We had over 300 submissions for topics, and we're going to do 60-minute workshops with live Q&A, 30-minute flash workshops. So, and that's going to be unique. And then a new venue we're bringing in, or a new platform, will be 10-minute express talks. So it's something like you've seen in the past in terms of some other labels that you've heard. We're calling them express talks. So going to be very innovative and creative, and that is on the 27th and the 28th of July. Stay tuned, go to NAMI.org, and again, registration will open on the 5th of April. We wish you all a very good close to your day, a wonderful Friday, and a great weekend, and thank you for being with us on today. And Ebony, cannot thank you enough for representing your body of work in CAHOOTS. All the best to everyone. Bye now.